Bismillahirrahmanirrahim. We will start our squint strabismus online course by the part 1 for the undergraduate Ain Shams University Faculty of Medicine students. I want my student to understand some applied anatomy and physiology and to understand the squint definition and the main 4 types of strabismus, and to be able to evaluate a case of squint and to know some of the sensory effects of strabismus as well as some of treatment modalities. The first aspect of squint study and squint presentation is a cosmetic aspect. We notice here this child before the operation on the left side and after the operation, after correction of squint on the right side. One type of strabismus is exotropia. Exotropia means the divergence of the eyes, as we see in this female with exotropia on the left side and after correction of exotropia on the right side. Another patient with more severe form of exotropia before and after. Another type of strabismus is convergent squint, what we call esotropia. This is the patient before the operation and after the operation. Notice the correction of the esotropia regarding the cosmetic aspect. More severe form of esotropia in another old age patient. So one of the presentations of squint is cosmetic, and it is an important goal of treatment of squint. Another more important aspect of strabismus correction is to see binocular vision. Binocular vision top is to see 3D as a view of the world as we see in this picture. That's what we call a single binocular vision. Before we go to study strabismus, we have to know some very basic anatomical and physiological principles. The types of eye movement are described around the different axes. We have a vertical axis, which is the axis around which the eye is moving in adduction and abduction, and we have the x-axis, which is a horizontal axis around which the eye is moving in elevation and depression, and we have y-axis around which the eye is moving in a torsional movement, intorsion and extorsion. While we are examining the actions or explaining the action of the muscles, we are talking about the right eye usually as a convention. All extraocular muscles are arising from the back of the orbit from the annular of Zen around the optic nerve, except for the inferior oblique, which is arising from the front of the floor of the orbit, and the superior oblique, which is functionally arising from the trochlea. Here we can see the superior oblique muscle arising from the back of the orbit and making a U-turn through the trochlea, so it is considered functionally arising from the trochlea. And here we can see also the insertion in the upper picture of the superior rectus, inferior rectus and medial rectus and lateral rectus in the front of the eye pole. And in the lower picture we can see the insertion of the superior oblique and inferior oblique in the back of the eye pole. That's why the superior rectus and inferior rectus are elevators, while the superior oblique and inferior oblique are depressors of the eye. Another important fact is the axis that muscle make with the axis of the eye. The horizontal recti, medial rectus and lateral rectus are nearly parallel to the axis of the eye. The superior rectus and inferior rectus are making an angle of 23 degrees to the axis of the eye, while superior oblique and inferior oblique are making an angle of 51 degrees to the eye, that's nearer to the being perpendicular to the axis of the eye. The medial rectus is mainly an adductor of the eye. The lateral rectus is mainly an abductor of the eye, because they are both parallel to the axis of the eye. The horizontal recti, medial rectus and lateral rectus are moving the eyes in adduction and abduction positions. They both have one action for each muscle, because they are parallel to the axis of the eye. The superior rectus and inferior rectus are mainly elevators and depressors of the eye. This yellow arrow show the superior rectus and white arrow show you the inferior rectus. So the superior rectus is mainly elevator of the eye, and the secondary actions are intorsion and abduction, while the inferior rectus is mainly depressor of the eye, while its secondary actions are extorsion and abduction. This slide shows to you the superior oblique muscle, which is nearly perpendicular to the axis of the eye, as we have seen before. So its main action is intorsion, and the secondary actions are depression and abduction. The inferior oblique is also nearly perpendicular to the eye, so its main action is extorsion and elevation of the eye and abduction. Please think about the action before studying and recalling the action. The inferior oblique and superior oblique are called cyclovertical muscle. They have a main action of intorsion and extorsion of the eyes, and the secondary actions are elevation and depression and abduction of the eyes. This table will show to us what is the actions, mainly the primary action and secondary or subsidiary action of each of the recti muscles, superior rectus and inferior rectus, and superior oblique and inferior oblique. The best position of examination of each muscle is different from its action. For the recti muscles, it is better to examine the eyes in the abducted position, and for the cyclovertical muscles, it is better to examine the eyes in the abducted position. We have 6 cardinal gazes for examination of the muscles in each eye. For example, to examine the left superior rectus, we move the eye in the abducted position and then elevate the eye. At the same time, we are examining the right inferior oblique, because the right eye is put in the abducted position and the eye is then elevated. So the best position of examination of the superior rectus is elevation of abducted eye, and for the inferior rectus is depression of the abducted eye, and for the inferior oblique is elevation of abducted eye, and for the superior oblique is depression of the abducted eye. The models of the eye movement are helping us to understand how the eyes move. The simplest model of the eye movement is the antagonist and yoke muscles model. We have an antagonist muscles which are moving one eye in an opposite directions, and the yoke muscles which are moving both eyes in the same direction, and the synergist muscles which are moving the same eye in the same direction. An example of antagonist muscles is the right medial rectus and the right lateral rectus, and example of the yoke muscles are the right lateral rectus and the left medial rectus, and the example of synergist muscle is the right superior rectus and the right inferior oblique, as both can help to elevate the eye. Here we have 2 laws for innervation of the extraocular muscles according to this model. The first is the Herring law, which states that there is an equal innervation to the yoke muscles. This helps to move the both eyes in the same direction and by the same amount of movement. The other law is Sherrington law, which is stating that there is a reciprocal innervation to the antagonist muscle to prevent what we call a cogwheel movement of the eye. The law of equal innervation to the yoke muscles will help us to have the pictures of the world falling on the fovea of each eye in different positions of gaze. This will help us to have what we call binocular single vision. It is a single mental impression of the world received by images in each eye. The requirements for the binocular single vision are sensory requirements regarding the image perception. They have to be good quality and focused and equal images in each eye, and good retinal and optic nerve function in both eyes. There is also a motor requirement that help the eyes to move equally in different directions, and there is also a cortical element for coordination of the visual input and motor output from the cortex. Binocular single vision is graded into simultaneous perception, then fusion, then depth perception. To understand the different stages of binocular vision, we have this machine for test for the binocular vision. It is called synoptophore. The grades of binocular vision can be described well in examination by the synoptophore. In the first grade, we give the patient two different images, and they are seen simultaneously and perceived simultaneously if the patient is achieving the grade of simultaneous perception. And in the second grade, in the middle, we show the patient two similar but incomplete images. He can see both of the images fused together. In this example, he can see the rabbit with a flower and tail, while the introduced picture are rabbit without a tail and carrying flowers on the right side, and a rabbit with a tail and not carrying flowers on the left side. So he can fuse the pictures to give the full picture in the stage of fusion. In the stage of depth perception, we introduce two pictures that are slightly dissimilar. Notice here the circles are different slightly from each other, so the child or the patient can see the depth perception, and this is the highest stage of binocular vision. The upper picture will show to you the normal fusion. It provides that the same circle is falling on the fovea of each eye, which are corresponding retinal points, while the lower left side is showing to you the confusion, which is resulting from the stimulation of two fovea, which are corresponding retinal points, by a triangle and circle, which are totally different images. So there is no fusion but confusion. And in the lower right part, you will see the diplopia. It results from stimulation of the two non-corresponding retinal points by the same object, which is the circle. So we see the circle bubbled. That's what we call the Waterfall dot test is another qualitative test of binocular vision. In this test, we put red-green filters. Red filter in front of the right eye. It will allow the right eye to see the red circle and the white circle, and a green filter in front of the left eye. It will allow the left eye to see the green circles and the white circle. Notice that the white circle is formed of the all wavelengths, so it can be seen by the right eye and by the left eye. If the examined person is normal, he will see what is described in the figure B. He will see 4 dots, 1 red and 2 green and 1 non-identifiable or in the yellow color. If the left eye is not working, he will see by the right eye only. He will see 2 red circles. If the right eye is not working, he will see only by the left eye 3 green circles. If the patient is squinting and having a good binocular vision, he will see the red circle in the right eye and the 2 green circles in the left eye, and he will see the white circle once in the right falling on the fovea and once on the left falling outside the fovea, and so he will see the white circle twice. That's what we call diplopia. It is described in the picture E in the slide. There are facts about binocular single vision. The golden time for development is the first year of life. the refractory time to develop binocular vision after 6 years of life. So to treat strabismus for binocular function, we have to treat before the 6 years of the child life. And the third fact is that binocular vision, once developed, it never breaks. Thank you for attention, and please wait for the second part.